Hey everyone, Ryan here from IKN. So in this video here, we wanted to explore the idea of using different movement models to help you make sense of the information that you gather during the assessment portion of your sessions. So when we're watching someone move, and that's what we're going to focus on more here in this video, and we are going to go through a practical representation of this towards the end of this video. But when we're watching someone move, we have to make sense of the information that we're gathering from their movement, how they're moving, okay? And how we make sense of that information will directly inform the decisions that we make. It will directly inform what we choose to do next, how we organize our rehab, how we organize our loading strategies, how we organize the process through which we're going to influence their movement, okay? So the models that you use act as filters through which you can filter the information through in order to make sense of that information. Because if you had 10 rehab practitioners in a room watching the same individual move, and you asked each individual practitioner what they would do to influence their movement, I guarantee you 10 of those individuals may have different ways to make sense of the information out there that they're actually looking at. And then 10 of those individual therapists may organize what they do next differently, but they organize it differently based on the models that they use to make sense of that information, okay? So in this video, we're going to look at two different movement models. One is a movement variability model, and the other is a ideal versus faulty movement model, or a kinesiopathological model, okay, that claims to understand or claims to know what movements are ideal and what movements are faulty, okay, or dysfunction, okay? And based on that model, they will try and, characterize the faulty movement and then work to promote the ideal movement, okay? Whereas a movement variability model doesn't necessarily judge movement as good or bad, but we are assessing the options that an individual has to move, okay? Now, this is hard when we're looking at the human movement system because you have so many options. And so we have to simplify it in a certain way. And that's why when you look at a lot of the research surrounding movement and variability models, they will simplify variability into two components: variability of the anatomical elements, the muscles and joints, and the variability of the task goal. But to jump back up here to the start of the slide, what is movement variability? This is defined differently across different research papers, but we like this version here that looks at variability as trial-to-trial variation in the patterns of muscle activation and joint segmental motion. So a variability in the behavior of muscles and joints between each repetition of a consistent task. So the same task can be completed, or the outcome of the task can be achieved with variable patterns of muscle activation and joint segmental motion, okay? So it's not necessarily a case of characterizing a certain muscular behavior as good or bad, or a certain joint behavior as good or bad, but trying to ensure the individual has options through which to complete that task. Now, this reflects how someone's moving here, the second point here, not necessarily how much someone's moving. So oftentimes you may have clinically, I'm sure if you're a rehab practitioner, you may see individuals with persistent chronic pain issues, movement limitations, and sometimes they just don't move enough. Okay. In those situations, if they're not getting enough physical activity, if they're not stressing their body physically enough, sometimes it's not necessarily worth hyper focusing on how they're moving, but it's you're going to spend your time much better by focusing on how much they're moving. Just get them moving, conditioning their body, engaging with physical stress and forces first before you actually hyper focus on how they're actually moving, okay? So to touch on these two components again, variability of the elements and variability of the task goal. Oftentimes confusion emerges here when we confuse the two, because if we are forming a task that has a clear outcome or a clear goal. So let's say, for example, I wanted to touch my nose with my right index finger. It's clear if I've achieved that task outcome, because if I touch my eye, I haven't achieved the task outcome. If I touch my mouth, I haven't achieved the task outcome. So there is reduced variability. There's low variability in the task outcome in that scenario because I'm touching my nose. If I touch my eye or my chin or my ear or my forehead, there's too much variability there in the task outcome. But I can achieve an optimal task outcome with a low variability in the outcome because I want to touch my nose, not something else. But I can achieve that task outcome with lots of variability in muscle and joint behavior because I can move my forearm in different directions, my wrist in different directions, my humerus in different directions, my spine in different directions, my head in different directions, and I can still touch my nose. So the individual in that scenario, me in this case, I have variation in the muscle and joint behavior to complete that task. That's a consistent task. I'm trying to touch my nose each time, but I can express variability in the patterns of muscle activation and joint segmental motion. Problems emerge when we try to, at least from an IKM perspective, and this is what we teach an awful lot in our courses, is that problems emerge when we try to say that there is one ideal way or perfect way to complete that task, instead of considering if the individual has options to complete that task. So they have variation. Now, the difficulty then, or not necessarily difficulty, but what we have to put emphasis on is how we are quantifying or making sense of muscle and joint behavior. That is the key thing there, okay? So when we assess someone, we want to understand first and foremost, what are we trying to see here? What do we want to see, okay? And if we're not seeing that, can we poke a little bit deeper to see, can they express that? You're not just watching someone move and then using their first repetition of that task as a complete representation of their movement behavior, okay? That's when problems emerge, and we'll talk about that in a bit more detail towards the end of this video. But how do we organize this to guide assessment and rehab from an IKM perspective? Well, we want to separate these components or these elements of the anatomy into muscles and joints. Okay, we appreciate that there's a lot more going on here. There's a nervous system that is connected to muscles and joints. There's fascia, there's tendons, there's ligaments. There's lots of other components, anatomical elements that need to be appreciated. But these models of movement aren't there to explain everything. You might have heard the quote that all models are wrong, but some are useful. That's what models do. They allow you to simplify the situation by ignoring part of the total information. So when you're making decisions from a rehab standpoint, you don't want to have to factor in all the information into your thought process, because then you'll never make a decision. You have to simplify the process first and make a decision based on something that's close enough to just get started. Okay, so that's why these models are helpful, because they're not there to explain everything. They're there to provide you with some utility to make decisions. Okay, to establish an entry point, to plan the first step. That's what you're trying to do. So we look at it from a local and global muscular variability standpoint and a local and global joint segmental variability standpoint. So muscles, we're obviously looking at their ability to lengthen and shorten, their ability to express different contractile behaviors. From a joint segmental standpoint, we're looking at the movement of the individual segments and how they interact with their neighboring segments. And then, of course, we're looking at the task. What is the task that the individual is completing? Very often, we'll watch someone do a complex task. And again, this is common with a gait analysis, for example. But the issue with the gait analysis is that there are many muscles and many joints integrating and cooperating with each other to complete that task. So it's very difficult to identify what might be limited, what might be problematic based on a multi-joint task, a complex task where there's multiple joints, multiple muscles behaving. And these are tasks that involve partial range of motion. So you're never really going to be able to tell the total range of motion availability at a joint just from watching a multi-joint task. You have to look at a simple task, simple joint motion. So when we're looking at things from a movement variability standpoint, we want to consider, are we looking at a simple task or are we looking at a complex task? Because we'll gather information differently from each one. Okay. So just to explore this difference between a movement variability model and an ideal or faulty movement model in a bit more detail and look at them both relative to each other. So, like we mentioned, a movement variability model promotes variability in muscle activation and joint motion during the performance of similar tasks. So I can touch my nose in many different ways. I'm not trying to tell you that there's one perfect way to touch your nose. I'm not trying to say that at all using this model. But I might say that if I'm using an ideal or faulty movement model, maybe touching your nose with a little bit of humeral abduction is faulty, and maybe doing it with less humeral abduction is more ideal. Again, obviously, we wouldn't say that, but that's what you might say if you're using an ideal or faulty movement model. So we can see how problematic that is, because it promotes the idea that there are ideal and faulty ways of aligning joints and activating muscles. A movement variability model is very, very helpful when we're trying to make sense of an individual's pain experience. When an individual comes to see us with a pain experience, it's very difficult if we are being honest with ourselves, and that's important as well. We have to have a standard of honesty here. We have to understand that pain is very, very complex, very, very uncertain. The people that claim to know exactly what's causing pain are not appreciating this uncertainty. When we are seeing people with current experience of pain, it's very, very difficult to establish what caused that pain experience unless there's a clear mechanism of injury and they're coming to see you with an acute experience of pain. But very, very often we are dealing with how their body has adapted in the presence of pain. That's very, very different. We are generally, at least from an IKM perspective, because we use this movement variability model to make sense of information that we gather, we are oftentimes addressing adaptations, movement adaptations in the presence of pain. Okay. So we can appreciate that pain will motivate a change in our movement system to adapt by changing variability. Maybe if I have pain when I flex my wrist, to achieve that task of touching my nose, I may not flex my wrist. I may do it with a little bit more wrist extension. That's going to change how everything else operates. That's going to change how everything else behaves. But I'm not trying to say that that creates faulty movement. I'm just appreciating that pain experience is going to influence how the motor system, your movement system, adapts in the presence of that pain. Okay. So it also appreciates the uncertainty of how pain influences our movement behavior. And we also then have to integrate this model of thinking with the unique individual, with their individual factors. What aggravates them? What eases them? Do they have past injuries? Do they have unique goals that they're trying to work towards? Okay, and then we also appreciate that there are multiple options available to us as practitioners to influence that movement behavior. Okay, how this compares to an ideal or faulty movement model is that it generally implies causation. It claims that it can identify the faulty patterns of movement that cause your pain, or that, this is even worse, that can cause future pain or injury. Okay. Again, hopefully you see the problem with that. Because pain is so uncertain and complex, making those kind of claims isn't honest. And it's you being way too overconfident with something that you shouldn't be confident about. You have to embrace the uncertainty. And how you embrace the uncertainty is by changing the way you make sense of information. You appreciate the uncertainty. You use a different model to make sense of what you're seeing, which affords many different options to approach that instead of saying that there's one option to do something. And it's built on certainty with little integration of unique individual factors. So this is the problem again with this model, is that it doesn't necessarily integrate all these unique individual features. It claims to be able to tell what's faulty, what's ideal based on just looking at your movements. A movement variability model doesn't do that. It doesn't judge good or bad. It sees the movement for what it is. It integrates what your current options are, and that integrates that with your unique individual factors to then integrate that information to make a decision on the best place to start from a rehab standpoint. Okay. And it claims to have the answer. The answer is, let's work towards correcting that faulty movement pattern by restoring the ideal movement pattern. hopefully, again, you see the difference between those two models of thinking, and hopefully you can appreciate them as models. Both these models are wrong. We're not saying a movement variability model is right and an ideal or faulty movement is wrong, but they're two different models through which you can filter the information that you're gathering to make sense of that information and then ultimately make a decision. But models need to embrace the uncertainty. Because a model ignores part of the total information, it has to embrace uncertainty. It can't say that if we're seeing this, this is faulty, this is the correct way to move. That's not embracing uncertainty. That's being dishonest. So we need to have models that embrace the uncertainty, that allow us to gather multiple sources of information to then make a decision. Okay, so up next, what we're going to do is we're going to look at this within the context of a very common movement assessment that we may perform. Okay, so let's use an example of a client that may come to see you with a current experience of low back pain. And as part of your objective examination, you want to watch how they actually organize their movement. So you may ask them to complete a forward flexion task, a toe touch. Now, using a certain movement model, you have to gather that information from what you visually see, and you have to make sense of that information to decide what to do next with that information, okay? So you may watch them move with a mental model of what's good or bad, which is that kinesiopathological model, and then you may already have the answer in your mind. You may already assume what the ideal movement is, and that's why sometimes you tend to see practitioners going through the motions with assessments because they already know what they need to correct. That's a big problem because every individual will come to see you with a very unique past injury history, a very unique pain experience, very unique goal tasks. So we have to organize our rehabilitation not just around what we're seeing from an objective movement standpoint, but also subjectively what they report to us about what they have trouble with, difficulty with, what their goals are, okay, and their aggravating factors as well. So when we're watching a forward flexion task, we have to appreciate, is that a simple task or is that a complex task? Simple task involving a single joint, complex task involving multiple joints moving together. Okay, that's a multi-joint task, it's a complex task, it's a multi-segmental task. So it's difficult to identify local range of motion with a complex task. We can use that multi-joint task with a bit more focus though and highlight local areas a little bit more so. So before we actually ask a client to complete this forward flexion task, we have to understand, what am I actually trying to gather here? What information am I trying to gather? Is it just how they touch their toes? Because if it's just how they touch their toes, there's lots of ways you can touch your toes. You can do it with a straight knee, you can do it with a bent knee, I can do it with potentially more of a hinge, I can do it with more of a flexion at my spine. So if you're only using the task outcome as that information, then you're not really going to be able to make sense of how they're moving, which means that you're not going to get that information about the variability of their movement. So when we're looking at a forward flexion task, we're generally looking to initially see, can the spine actually flex? And then can the pelvis rotate forward over the femur, okay? So let's say you see something like this. You ask a client to touch their toes. Initially, you're just looking at their self-selected strategy. So you're not necessarily seeing what they have available to them, but you're just looking at how do they choose to do it. So this is that idea of not just using the first repetition to guide your thought process. So let's say you see something like this. So you ask them to touch their toes and they do something like that. And they report that they have a pain experience in their lumbar spine. We'll just keep it simple here. You have to ask yourself, well, is the spine actually flexing in that scenario? No, that's more of a hinge. It's more of a posterior translation of the pelvis, and my spine is staying relatively extended as the pelvis rotates over the femur. Whereas if I wanted to gather information as to if they could access that spinal flexion, then I would just give them a bit more cueing. I would ask them to get a little bit of a rotation backwards of their pelvis. That rotation backwards affords the ability of the spine to flex over top the pelvis, and then for the pelvis to move over top the femur, but with more of a flexion at the spine. Okay, so this is why it's important to not just use the first repetition of a task to guide what's happening, but also why it's important to understand what we're actually trying to look for early on. Now, does that mean that the hinge is dysfunctional or problematic or faulty? No, it doesn't. It just means that that is the strategy that they're using for that first repetition. It may be a case where they're using that, they're only engaging with that strategy to touch their toes or to bend forward. Okay, so maybe on a day-to-day basis, they may be fearful of spinal flexion. Their beliefs may have influenced how they choose to organize their muscles and joints. And maybe it's the case where the spinal extensors aren't getting that opportunity to lengthen and share that force over a broader surface area. Maybe they're just concentrating the movement at the pelvis and not giving the spine the opportunity to flex over the top. Okay. Now, it may also be a situation where you ask a client to touch their toes and you see something like this, where you see them reach to here and they have a pain experience, they can't move any further because it's either limited or painful. In that scenario, we can see that I'm able to flex my spine, but my pelvis isn't moving over the top of my femur. Okay. In this scenario, they may have the ability to access that spinal flexion, but they may not have the ability to move the pelvis over top of the femur. Okay, which is reducing the sharing of load, the sharing of range of motion across multiple segments. So perhaps for that individual, with that representation of movement, it may be a case where instead of trying to promote more spinal flexion, we may want to promote more pelvic forward rotation over top of the femur to just give them more movement options through which to share that range of motion over more segments, more joints, and as a result share that load and force over more muscular tissues. Okay, because that's going to give us the opportunity to share that load into the posterior hip as opposed to the spinal extensors, as we only flex via more of a spinal dominant strategy versus a pelvic dominant strategy. Okay, so using a movement variability model, we're not characterizing one strategy as good, the other as bad. We're just gathering information as to what they're currently capable of, and if they have the availability to do that using other options. The thought process here is that a certain movement strategy is not good or bad. It's that if they only have the option to do it using a certain strategy, and that they're avoiding other options, or they don't have the ability to access multiple options, then that represents a lack of movement variability from an anatomical standpoint. So then we want to work towards promoting more movement options. But in order to promote more movement options, we have to understand what they're limited in, what they're avoiding, what they can't access. Again, it doesn't mean that what they can't access is ideal. It doesn't mean what they're currently expressing is dysfunctional or faulty. It just represents a lack of movement options or a lack of movement variability. Okay, so again, this is just one test that we can use to highlight the difference between these two different models, but really it highlights the importance of using models, different models of thinking to guide your thought process. Everything during the assessment is about gathering information. Okay, and I always use the example of, if you were to give me a carpenter's tools, I have all the tools available to me to produce beautiful pieces of furniture, but I'm not a carpenter. Those tools have no intrinsic value. The value lies in the way I decide to use them. Okay, I am what gives them value. I give that information, those tools, value. Okay, that allows me to then make those beautiful pieces of furniture. Okay, it's the same thing with movement. Anybody can watch someone move. Anybody can move a joint. Anybody can move a muscle. But it's about the value you're attributing to that and how you're using that information, how you're making sense of that information in order to guide your decision making. What are you going to do next? What information are you using to arrive at a certain decision? And this is the key point for us, is that if you're using an ideal versus faulty movement model, saying that one is bad, one is good, and that's why I'm trying to chase the good, then that for us doesn't really embrace the uncertainty of movement and particularly pain. But if we're using a model that is guided by variability in movement, variability in muscle and joint behavior, then I think that opens up more pathways to rehabilitation. and it gives you, the therapist, the practitioner, and the patient the opportunity to explore different options. Okay, and that's what's key. Okay, so again, it is a complex area, and it might be a different way of thinking for a lot of you out there, but hopefully it makes sense. And of course, if you have any questions, please let us know below.